Welcome to this video lecture on targeted exercise selection in rehabilitation, the basis for the two-pronged approach, the top-down, bottom-up approach. I'm Dr. Scotty Butcher, the Strength Jedi, and co-founder of Strength Rebels. So when I think of exercise selection, I always think about the international classification for function that classifies function into participation level, the functional level, and impairment level. And we always have to consider the participation level of the individual and what they want to do. But if we look at most tasks and look at different activities of daily living that are important to individuals, we can take the participation level function or participation level activities and break them down into common functional goals. And then what we can do after that is then identify specific impairments that go beyond that. So when we're thinking of the functional level, we're often talking about global movement, and this would also apply to the participation level. This would be movement that encompasses the whole body. So here are some examples of some of the functional level tasks that would relate to different function or participation level tasks, but would be the specific body movements and the potential for having impairments addressed in any of these individual patterns. So these would be the common patterns that we would look to address, and certainly there are others, but these would be probably the most common ones. So this would encompass whole body mobility, strength, control, repetition, and endurance of these patterns. I've classified these patterns into two different classifications: the base level functional patterns, crawling, rolling, breathing, hinging, arm elevation, twisting, walking, brachiation, that sort of thing, and the higher functional patterns, which would be the ones which would involve more whole body movement from a functional perspective, deadlifting, squatting, rowing, pressing, overhead lifting, pulling, lunging, loaded walking, and that sort of thing. And so you can see that this would be the basis for most of the exercise prescription that I would provide would be at the higher level, global functional level, with some inclusion of the base functional patterns as needed. So when we start thinking of the impairment level, we often think about exercise that would then go to the regional level, which would be separated into the trunk and the quarters, so arms, legs, and the trunk. And these would encompass the integrated movement patterns that would also include mobility, control, strength, etc., but would be more regional in focus. So lumbo-pelvic dissociation, knee tracking during squatting or lunging, scapulohumeral rhythm, core stability, control, body weight support through the arms, gripping and grasping, and foot posture and things like that would all be considered at the impairment level and the regional level of impairment, so where there's more than one muscle group involved or more than one joint involved and involves an integrated pattern, but not necessarily whole body. And then we can break it down from an exercise perspective to the isolated level of the impairment level, and this would be where we have isolated concerns relative to either muscle range of motion or flexibility or mobility, joint range of motion, anatomical integrity, the healing of a structure or the anatomy that presents in front of you, the muscle strength, as well as tendon and ligament strength. And any of these could be targeted goals. So using a sit to stand as a participation level function, we often think of the sit to stand as being synonymous with a squat and the squatting pattern, which is a whole body type movement. And of course, it doesn't have to be a barbell back squat. It could be a sit to stand with any sort of load or simply body weight. This would be at the global movement level and at the functional level. The impairment level, we might see an issue with the squatting or the sit-to-stand pattern, let's say when we talk about knee tracking. And so this would be still the global movement, but we might be wanting to address something that's a bit more regional. So we might have exercises that focus at the impairment level on the regional level, or we might find that from an isolated perspective, we may say, well, this may be because of either weakness or lack of control of the hip movements as they relate to the gluteal function. And so there's certainly a relationship between all of these different levels, and we can target any of these levels when it comes to our exercise prescription. So there's certainly a relationship between the different levels of function and impairment, and we can see that one can have an impact on the other. So, for example, if we have an impairment or a limited function, this can cause impairments at the impairment level, at the isolated or regional level. A good example of this would be someone who is sedentary and has global deconditioning, and this causes impairments in mobility and strength, potentially range of motion, endurance, flexibility, any of these things, as well as many others that sedentarism does cause. We also know the reverse is true. If you have an impairment at the regional or isolated level, so this would be an injury or this would be a specific illness-related concern that would affect a particular body part, lung disease as one example. If we see an impairment level problem, can limit functional performance. Of course, if you have these problems, they can limit your ability to perform at the functional level. So when we think about how to address that, if we go from a function level first, we see that training function often improves the impairments that we see. So if you're able to train at the functional level to at least a certain degree, we can usually see some improvement in impairments if those impairments are improvable. So it depends on the type of limitation that they have, and if it's not a fixed limitation where it won't improve, we will see usually some improvement in overall strength, overall endurance, overall mobility and range of motion by training people at the functional level. And of course, the way our brain is organized is designed to work at the functional level. So the more we can do at the functional level, the better it is in terms of transfer to the participation level. The problem comes is when we think about the opposite, and we think about training at the impairment level. Training impairments alone, we know this has a very small impact on global functioning. So we do know that if you train at the regional level or isolated level, that might be needed, but it can't be the only thing. It can't be. You can't expect that improvements at the isolated or regional level will have an impact on someone's function at the top level. So what do we do here? Well, we want to think about function first. And this is the basis of the top-down, bottom-up, or the two-pronged approach, is to think about function first, but then also target treatment at the functional level and work regional and impairment level problems as necessary. So, to show what this actually looks like. So if we think about the different types of movement from global to regional to isolated, we do think about targeting our exercise selection at the global level first. And as in my exercise selection process, I'm always thinking about the function first and the global movement first, but also identifying the fact that there's also going to be some impairments that need to be addressed in many situations. So we would address the impairments at the regional isolated level as identified in any sort of movement assessment that you're doing, and usually this is simply the movement assessment of the global movement. So if we're using the squat as an example, we would watch someone squat and we would see, are there any impairment level problems that we might need to address individually, either regionally or isolated, or maybe they could be simply addressed through function. But if they need some targeting, if for example the hip and knee tracking needs a bit of targeting, we might do some supplemental exercises to assist with that, along with whatever changes we make to their squatting pattern. Or it might be a specific injury or illness concern that you identify as part of your specific assessment process. So this is where we go from top down, bottom up. And so our top down exercises are our global functional exercises. Bottom up exercises are the impairment level, regional or isolated type exercises that we would do to support the global functional level. So what does this look like from an actual pattern perspective and an exercise selection perspective? So global patterning progressions, we often think about finding acceptable patterns through some range of motion. So for example, if someone has a decent squat at the top end, but has difficulty with a deeper squat, with maintaining knee tracking, or any other concern that they have at that lower end, we would do squatting or sit to stand type patterns at the top end. We would limit the range of motion to what we would consider acceptable movement, and not exhibiting any of the problems that we would see that might be causing whatever issue there happens to be. So if they have good control of movement through some range of motion, we can do some sort of loading here. So I usually call this early short arc training, and I would start this at the very beginning of the rehabilitation process. So this would be in contrast to many of the other models out there where they start at the isolated level, move to the regional level, then to the global level. I'm always starting at the global level with whatever movements I possibly can. Now, that might not be anything, depending on what the control is, what the state of the injury or illness is, or what the state of their functional movement is, but that's always where I'm starting to try to begin. Now, I might need to back off and do some early control work if they don't have a good hip hinge, for example, and I want to improve their hip hinge before I start getting into doing more squatting patterns. Then I might back off and do a little bit of that first, but the idea is to get them back into the global pattern, like the squatting pattern, as early as possible, even if it's short arc, and then I can load it as best as I possibly can. But at the same time, and this is literally at the same time, we would do this during the same session. We also provide homework along this, home exercise program along this line as well. We would address the regional patterns to support the global patterns. So this is where I'm going to give exercises that would support the change that I want to make in terms of the movement patterning, or work on the specific weaknesses, or work on the specific movement faults if I can identify a movement fault at this point. So this could be restoring or optimizing range of motion, looking at whatever limitations to performance or activity there are there. We do want to consider protection of the acute or subacute illness or injury if that happens to be present in our clients, and as well as individual muscle strength, power, and endurance. But as we know, most of these situations, as I mentioned in the previous slides, don't have a direct impact on function if we're not training function. So this is where we train them both at the same time. So to give an example, keeping along the squat example, we would start potentially doing box squats or elevated chair squats, emphasizing technique first, then reps, then load. And this would be a common progression pattern. But this would also be in the case where someone does have an injury. And so considering that I'm still going to do these things in the presence of an injury, but at the same time, I want to address what the injury concern is, or what the lack of mobility is. So do they need some hip range motion work or some deep squat mobility work at the same time? Working on dynamic balance with knee control, isolated quad, glute, rotators, hams, whatever isolated muscle work that you think you want to do. Throw in some clamshells if you like. And any other therapeutic or accessory work that you feel is needed can be supplemental to the functional or global level movement patterns, in like box squatting or elevated chair squats. So when we look at the isolated exercises, we do also have a hierarchy here. We're making the assumption in many cases that the individual has a 3+ out of 5 grading for their manual muscle testing, and they're able to do functional patterns, but sometimes we get in the situation where there aren't. So what do we do when we think about isolated exercises, and what's the hierarchy there? Well, if I'm giving isolated exercises, the best situation would be to provide active resisted exercises when they're stabilizing their body parts themselves. Individuals that have some specific weakness, and we start thinking about neurological populations now, sometimes you need to get into doing external stabilization, but then you're still able to give some active resistance, active against gravity, and then moving down into active assisted, which is either self or therapist assisted, and then finally down to the bottom, which would be the passive movement. And of course, we'd want to start as high up in this hierarchy as we possibly can, and then work upwards until they get to the point where they can self-stabilize and have some active resistance. So as a summary, the top-down, bottom-up model gives us a chance to provide some major movement pattern progressions, which might be short arc, they might be modified, but they're at least getting at the functional level and the global level, and training at that level to try and carry over in terms of once we improve some of the bottom-up issues like movement mechanics or mobility, we try and get through as much range of motion as possible with those ones as well, and eventually over time the progressions of each allow us to be able to eventually get full range of motion, whatever's full for that individual for that movement pattern, and hopefully loaded through as much loading as we possibly can.